Our next paper is the development of a convolutional neural network to detect infrarenal abdominal aortic aneurysms by Dr. Justin Kamara and colleagues from Loma Linda University, School of Medicine, Loma Linda.
Hi, my name is Justin Kamara. I'm a radiology resident at Loma Linda University, Department of Radiology, and I'd like to start my talk by thanking the VESS 2021 Annual Winter Meeting for the opportunity to present my research. Myself and my co-investigators have no disclosures. Abdominal aortic aneurysms are often found incidentally on imaging exams, and surveillance is an important part of monitoring disease progression. As a result, automated detection may reduce errors in diagnosis and assist with surveillance. Our primary research question then is, can we train a convolutional neural network binary classifier to detect abdominal aortic aneurysms on CT imaging? We obtained retrospective IRB approval for collection of CTs of abdominal aortic aneurysms. We collected 200 abdomen and pelvis CT angiograms of infrarenal abdominal aortic aneurysms between 2015 and 2020. We matched these to 200 propensity-matched non-aneurysmal control CT angiograms, and then we divided these into 60% training, 10% validation, and 30% test subgroups. Here we have an example of a convolutional neural network. The basic premise of these types of machine learning is that data is fed into the network and coefficients at different layers of the network are predicted in order to generate an output, and then the error of that output is estimated, and then this whole process is iterated over and over in a cyclic loop in order to improve prediction. For our analysis, we selected the VGG16 neural network architecture. It is a neural network architecture that performs well on a variety of tasks. We boosted the performance of this neural network by applying augmentation, which takes a base set of images and applies changes to them to generate a larger data set from an existing smaller data set. We also applied transfer learning, which involves using a network that is pre-trained on a large set of non-specific images, and then taking that model and using it for a specific task, which allows the model to be trained more quickly and more accurately. And we also iterated multiple model parameters to arrive at the best performing model. For our analysis, the aneurysm and control groups had similar major risk factors, including age, gender, hypertension, and tobacco use. These figures demonstrate the performance of the model as it's training over multiple epochs. An epoch is just a cycle of training. On the left, the graph demonstrates the level of error at each epoch, and you can see that it trends downward as the model was trained. And then on the right, this graph demonstrates the accuracy of the model as it's training, and you can see that the accuracy trends toward a high value or a maximal value. Here you can see that the area under the receiver operator characteristic curve is excellent at 0.99. The accuracy for the model was very good for the training and validation subgroups. And overall, these findings support that the model is sensitive and specific. In order to better analyze the performance of the model, we generated a confusion matrix, which is the machine learning equivalent of a 2x2 table from clinical medicine. And you can see here that on the left, we have the predicted, or in clinical medicine, you might say the test result. And on the bottom axis, we have the ground truth label, or the true disease status. And when analyzing aneurysm versus non-aneurysm, the most common errors for the model were false negatives, giving the model a very high specificity of 100% and a fairly high sensitivity of 89.5% for this particular analysis. Here we have two examples of correct classification. The feature maps show that the areas of interest that were most influential for the binary classification are highlighted. Here you can see two examples of incorrect classifications, specifically false negatives. Both of these images were small aneurysms in the range of 3.3 centimeters with mural thrombus. These tended to be the types of images that the model struggled with. In the analysis of 6,175 infrarenal abdominal aortic aneurysm images versus 6,175 control images, our model had a sensitivity of 97.1%, specificity of 98.0%, and a test subgroup accuracy of 97.5%. In conclusion, the VGG16 neural network architecture, in combination with transfer learning, is very sensitive and specific for detection of abdominal aortic aneurysms given a moderate sized data set. False negatives tend to be slightly more common than false positives. And when the model does make errors, misjudgments tend to be small aneurysms with thrombus. We have a couple questions to build on the results of this project. First, we would like to assess whether we can train a neural network classifier to detect endoleaks and other complications on CT imaging. And then, in order to take this and make it most clinically applicable, we would like to collect longitudinal data that can be paired with imaging to test if a neural network classifier can predict outcomes or complications of these diseases. I'd like to give a special thanks to my principal investigators, co-investigators, and the others at Loma University who have mentored me in machine learning.
Okay, that was a great talk. While the questions are coming in, I have a couple questions for you. First of all, can you talk a little bit about the size criteria? I know you said that the model has a problem differentiating between small aneurysms with thrombus. What percentage of your aneurysms were actually small versus 5.5 or 6? Did you have a lot of large ones in there, or did it range throughout?
You know, so when generating the data set, I basically went back and searched through our PACS database to pull up aneurysms that had been designated as aneurysms. And so I included just sequentially everything that had been classified as an aneurysm, with the exception that occasionally things had been classified as aneurysms and you go back and you double check the imaging and it's like 2.8 or 2.9. So I included anything that was above 3. But I don't have a percentage for you as far as the breakdown for what the size range for aneurysms are. And that's a good question. It can kind of give you an estimate of how many were small and how many of the small ones were missed. Yeah.
Yeah, because that would probably affect your sensitivity and specificity over time.
Absolutely.
One of the questions from the audience, I'm supposed to remind you to take your tie off. This is a conference where we don't wear ties. So no, please take it off. We're going to ask you to do that. it's the shaming so that no one else wears. But thank you, I appreciate that. Next question: what's your ultimate goal here? Are you trying to replace yourselves as radiologists, or trying to predict the future? Because I feel like you guys read these all the time and call out the aneurysms.
Well, there's probably a couple applications here. As far as things to not replace yourself, once we test the model on things like non-contrast and make sure that it's robust in a variety of settings, in theory, you could just dump an entire hospital's database of CTs into it. Just make sure you never miss anyone in the background. But the bigger picture is that I think that the goals for anything like this is to actually increase the speed and actually the volume of images available and drive down cost. And hopefully we as radiologists and surgeons and whoever else is interpreting these can just do more good work. I mean, that's my thoughts on it.
So almost like an EKG where it gives you a computer printout first, and then you can read the rest of things on your own.
Yeah, I think that there's always going to, at least from my perspective on artificial intelligence overall, we need people to manage the robots.
Question from the audience: how would this work in practice, given that you have already matched the patients 50-50? So you already increased their sensitivity by introducing this bias. In reality, the data is highly imbalanced. Is that true?
So one of the things that is a struggle with any of these imaging tasks, you generally have some or a few number of disease images, and then a vast majority of quotes unquote normal, or I guess I would say images that are not in your group that you're trying to identify. We have tested, and I didn't include all of the results in this short presentation, unbalanced and balanced test groups. And the model does actually perform quite well, even with an imbalance ratio up to, say, 6% or 0.06 or 0.6. So you can get pretty far on balance and still maintain relatively good sensitivity and specificity. I haven't tested how far you can push the imbalance and see when your performance really drops off. But we do have data sets that we've tested with good performance with a significant amount of imbalance.
Another question is, what other types of vascular diseases do you think approaches like this will be able to analyze in the future? Like arterial stenosis?
Yeah, I anticipate that it could. With each imaging task, there is the finesse of figuring out where does the model struggle. One topic I didn't specifically bring up here, right, is that a lot of times you have people with vascular disease along the whole extent of the vascular tree, and so you're dealing with your model having to differentiate between thoracic versus infrarenal versus other areas of disease. And so I think it can perform well, but each task will have specific areas where the model may be tripped up or struggle with the performance.
I noticed that your pictures that you showed us were axial images, and they look pretty straight. Is there a way to teach this model to do centralized measurements so that they can account for any angulation?
So I couldn't answer that question directly, only because I don't know if there's a way to easily correct for different changes in angulation. As far as actually generating measurements, we did a binary classifier, but it's also possible to do a linear variable as the prediction for these models. So it is possible to predict continuous variables, not just categorical variables.
Did it overcall any small aortas as being aneurysmal if they were tortuous?
It from when we did the full set of like 6,000, but it was balanced. There were a few in there. Basically, the ones that ended up being false, the overcalls, tended to sometimes be where you had a situation where you had a thoracic aneurysm extending down into past the infrarenal, or again, there were a few where it would overcall, but not nearly as many as the opposite, which is where like a 3.3 might be claimed as to be not an aneurysm. So I guess one of the things, and I purposely included all of the thoracic disease and iliac disease because we want the model to be as robust as possible against those possible confounders.
And our final question, can we expect to receive referrals from bots in the future?
I hope not. Man, my phone already gets too many notifications.
All right. Well, thank you for a wonderful talk, and I'll throw it back to Jason.